Thank you very much. I'd like to thank the organizers for inviting me, and it's my pleasure to discuss the role of influenza vaccination in patients with or at risk of heart failure in this great session on the emerging concepts of immunology and heart failure. These are my disclosures. I plan to use generic names of products in concordance with practice guidelines, but we will be discussing some potential off-label use of therapies that have been tested in clinical trials. And the other commercial interest relationship that's of relevance is that Sanofi Pasteur makes influenza vaccines. So in past, when I presented the slide, it's taken the audience really a lot of creativity to understand what could have possibly been the mindset of the population back 100 years ago during the Spanish influenza pandemic, as we're now a few years past the 100th anniversary. But in the time and era of the COVID-19 pandemic, I think it is much better appreciated exactly what our ancestors probably went through 100 years ago. If you may recall, in 1918, as the boys were coming back from World War I, this pandemic ravaged the world. Over 800,000 lives were lost in the US and Canada alone. It was considered the most severe pandemic in recent history, and now I think it will be on par with COVID-19, killing more than 50 million people worldwide. So thankfully, we're not that bad. But as you can see in these images that were taken, either of a sanatorium in the top left-hand corner, or just kind of, again, the signs and warnings or the recommendations about open air meetings and keeping window open for preventing influenza, pneumonia, and tuberculosis. So there were so many different contagious illnesses back then. We're living through that right now. And I think there are a lot of lessons learned in history, as they say, and history does repeat itself. So here we are. And again, I think it took folks a while to kind of process this at times, but now I think you can compare this with what has been reported in the lay press, and I'm sure you're very well aware. So, like COVID-19, influenza has a pretty substantial impact on millions of Canadians and Americans' lives each year. And that disease severity can vary by season and age, as we've already seen in this new emerging respiratory infectious illness. And so shown in the left-hand inverted pyramid is, that cases range from asymptomatic cases to cases that could be severe with pneumonia or cardiovascular complications or even fatalities. And so every year it ranges from several, tens of millions to potentially 50 million cases. This is in the US. We mirror that in Canada, about a 1/10 of those usual cases based on our population differences. Hospital admissions at around 100,000 to 1 million each year, and deaths range from anywhere from tens of thousands to 100,000 each year. And that burden of outcomes can vary based on the predominance of the circulating strain of the virus. The particularly nasty strain of the virus that seems to trigger a lot of an immune response and pulmonary and cardiovascular complications is the AH3N2 predominant strain. Shown you here are three on the right-hand side, different prevalence rates that year of the H3N2, and then stratified by age ranges, the hospitalization rates per 100,000 population. As you can see, older folks are at higher risk, but there are substantial illness as well in those who are middle-aged, and those rates vary, again, according to which strain is most predominant. As we've seen with COVID-19 as well, risk factors that are related to folks being hospitalized with influenza seem to, again, coalesce with those who are at risk for cardiovascular disease. So shown some representative seasons in the last few years, that on the left-hand side, the most predominant comorbidity was cardiovascular disease, as well as in under metabolic disorders, diabetes, the two of the most predominant forms of manifestation of cardiometabolic disease. And interestingly, and we've seen this with COVID-19 as well, obesity, maybe that reflects, again, the North American prevalence in the population in general, but these patients are particularly high risk for hospitalization from influenza, as well as those with chronic lung conditions, neurological conditions, kidney, immune suppression. These are things that we, I think, take and understand even from medical school. What's important to realize is that over 90% of those who are hospitalized have at least one chronic health condition. So very few patients are hospitalized if you have none of these comorbidities. It's been studied now from almost 20 years ago, where in this self-controlled case series analysis, where people who had complained to their primary care physician of influenza-like symptoms were then followed to see whether or not they developed any cardiovascular events. And so using the UK practice registry on the left-hand side, 20,000 incident MIs, on the right-hand side, 19,000 incident strokes, within days of presenting with influenza-like illness symptoms. And so 3 days, the peak 5-fold increased risk after adjusting for comorbidities and age. And that incidence rate would start to trend down back to the background rate within 3 months of the onset of the illness. On the right-hand side, that stroke rate would be increased by 3-fold within the first few days, again, trending back down to baseline. Shown as a negative control is the rates associated with flu vaccines, not to suggest they're protective, but just to demonstrate that they're pretty much, neutral with regard to triggering the onset of a cardiovascular illness. My colleague Jeff Kwong used data from the ICES, so Ontario Linked Administrative Health Registry data, as well as linking to respiratory data from our labs in Ontario, to look at a similar question in terms of looking at patients' background risk coming in with an influenza-like illness and what their risks are for a heart attack. And so they found on the left-hand side that risk increased from about a background risk of about 3 per week in Ontario to about 20 per week after the incident of a lab-confirmed diagnosis of flu. Within the first 7 days, that was a 6-fold increased risk that kind of regressed back to baseline fairly quickly thereafter in the modern study here that was done just a few years ago. It was also shown that not only influenza A, which I had mentioned with H3N2, but influenza B actually, which usually is pretty benign in older folks. So if you get a bad one, you ended up in a hospital, it's a pretty bad infection. It's associated with a 10-fold increased risk. But it's not just influenza, as we now know with COVID. RSV, another pretty common circulating respiratory infection, 3.5-fold increased risk. Generic respiratory viruses, 2+ increased risk, and even respiratory infections that weren't actually identified as what the etiology was, 3-fold increased risk. So these are not new findings that we're dealing with now, and we're still trying to figure out exactly how we can prevent them. And what is the mechanism for causing this? Well, respiratory infections stress the system, particularly those systems that trigger cardiovascular illness. And so you can imagine coming down with pneumonia isn't good in terms of your likelihood for impaired gas exchange, for sympathetic activation, high blood pressure, hypercoagulable state, tachycardia. There's vasoconstriction on the endothelium as well as just a SIRSI-like response with impaired electrolyte balancing and renal mechanisms of basically handling volume status. And then some of what those start a cascade of risk for potentially ischemia or non-ischemic myocardial or pericardial injury and inflammation, as well as the risk for heart failure. And then some of the therapies we use to help support patients, including potentially pro-arrhythmic antibiotics that are inappropriate to be using in someone with a viral infection, or even IV support with saline, could lead to triggering and further exacerbating cardiovascular events. But we also know, and we've seen this again with COVID-19, that there is evidence for direct cardiac injury from influenza as well. We've seen signs of, again, on the tip of the iceberg are these clinical manifestations of acute myocarditis or patients who have some sort of low-grade elevation in troponin levels, complaining of SIRS-like symptoms. But we've seen again, in necrotopsy analyses that we've seen focal infiltration of inflammatory cells, interstitial edema, and cardiac necrosis as well. So we've seen this in about 10% of patients who likely are presenting with the most severe manifestation of influenza. Usually most cases are mild and resolve spontaneously, but as we get more sensitive biomarkers and imaging and ability to detect milder and milder disease, we're seeing that this might, again, as I mentioned, be the tip of the iceberg, and likely there is some low-grade smoldering in cardiac inflammation that is associated with this inflammation, this infection, and other respiratory infections. So about 25 years ago, Kirsten Nickel and her team did the first analyses here, these observational studies adjusting for differences between patients who did and did not receive a flu shot, and showed that you can demonstrate that those who received flu shots over various seasons had a lower risk of pneumonia, about 50% lower risk, particularly in those who are 65 years of age and older. And as well, there was some suggestion of benefit, particularly of reducing the risk of congestive heart failure amongst those same patients. It wasn't significant in every season, but it was a hint towards potential benefit that was a borderline significant after adjustment. And this, was again very motivating for further study. She studied one of the last, efficacy and ethical randomized controlled trials, particularly amongst younger people who don't necessarily get the flu shot or don't believe in the flu shot. They feel they're impervious to the flu shot. So, for those of your colleagues who don't understand why you get the flu shot, this is from the best data from a randomized study of almost 1,000 patients. Those who got the flu shot compared to placebo had a 20% lower risk of an upper respiratory tract infection, a 36% lower risk of sick leave due to a respiratory infection, and about a 40% reduction in needing MD visits, let alone any kind of more severe presentations of respiratory infection. Again, our team was looking to generate the evidence to support the idea that influenza vaccines may be cardioprotective as well. And so we performed a systematic review of smaller RCTs that were published in JAMA a few years ago, where we looked at either vaccine trials that had recorded cardiac events as part of a safety profile, or with regards to efficacy studies of patients with coronary disease for the purpose of studying cardiac outcomes. And across these several trials, we found a 36% reduction overall in the next year after patients were randomized to a flu shot versus either placebo or open control, for a reduction in CV death, MI, stroke, heart failure, or other cardiac manifestations, translated into an absolute risk difference of about 1.7%, or a number needed to vaccinate to 58 patients to prevent one MACE event in the next year. We hypothesized that those who are at highest risk, as I mentioned earlier, likely would have the most cardiac benefit. And so even though there was a 36% overall risk, those who had been randomized in those coronary trials with an ACS presentation, acute coronary syndrome, had actually over a 50% reduction in their MACE risk in the next year compared to those who were enrolled in trials who had stable coronary disease. That was a significant difference with regards to the interaction p-value, and translated into an absolute risk difference of about 13% in those patients, a number needed to treat of eight patients with an MI that we see probably on the wards each day at our institution at Toronto General Hospital, to prevent one MACE event in the next year. A pretty powerful finding. However, we know that across Canada, there's still low rates of uptake of seasonal influenza vaccine for various reasons. There's lots of skepticism. There's also probably some conspiracy theories. And then there's a lot of just, again, libertarianism and the belief that they're impervious to the illness, or that it's not natural to be vaccinated against an illness. None of which, of course, as you know, is actually based on any science or evidence. And so 36% of all Canadians have, unfortunately, is all that we've been getting for flu. Now, this year we were hoping for more, but unfortunately, I think we've also underappreciated the demand this year. And so our targets are to be aiding at 80%, and we're only seeing that in those who are 75 years of age and older who have at least one chronic comorbidity. And so we're really underutilizing the flu vaccine. And that's not just the case in the general public or those with comorbidities. Here in the analysis of the Get With the Guidelines Heart Failure Registry, we found that only a third of patients who are hospitalized with heart failure are getting vaccinated. So only 1 in 3 are getting vaccinated, or getting vaccinated. The rest are not getting vaccinated. The rates have not improved over the last 5 years. And the problem in part is that I think, at least in part, that we have a difficulty with regards to knowledge translation, in that we test flu vaccine effectiveness and usually report that in young, healthy individuals. But it's in those who are at highest risk of these adverse outcomes are those who actually have the least amount of an immune response to a standard flu shot. And that term of immunosenescence, where the immune system doesn't robustly respond to the same amount of antigen a flu vaccine shown, is actually been well known for many, many years. Here, showing you some data showing you that the vaccine effectiveness is almost essentially half of that of younger, healthy people. We did a pilot study a few years ago where we tested in patients with heart failure, ischemic and non-ischemic heart failure, whether we could boost the immune response with a higher dose vaccine. So we just kind of concentrated the vaccine, here being a double dose or a doubly concentrated version of the standard flu shot. And you can see on the left and right-hand panels, either because of seroconversion based on numbers of seroconversion at an absolute scale, or in terms of their actual immune response, we can boost the immune response for all 3 types of flu strains in the flu shot by giving more antigen to patients with heart failure. It really suggested that we could potentially show reduction in outcomes as well, pulmonary and potentially even cardiovascular, with a better flu shot, perhaps. And so there was a large outcome study of almost 32,000 patients that generated the evidence for high-dose flu vaccines in those who were 65 years of age and older. So again, with reduction in 24% for influenza-like illness, 29% reduction in pneumonia, and there was a borderline statistical significance hint at a secondary, non-specified, so hypothesis-generating outcome of cardiorespiratory infections and hospitalizations could be reduced with a higher dose influenza vaccine in those patients who are 65 years of age and older. So we went on to test that in the study that we call INVESTED, that was funded by the NIH and the NHLBI. We looked at patients who were 1 year after a heart attack or 2 years after a heart failure hospitalization and enriched for one additional risk factor, and they were randomly double-blind assigned to either the high-dose trivalent flu vaccine or a standard dose quadrivalent flu vaccine, which was considered the standard of care at that time, across all different age ranges for the last 3 flu seasons on a background of other evidence-based cardiovascular therapies. We followed them up several times a year to test whether or not we could reduce the outcome of death or cardiopulmonary hospitalization within each flu season, and we looked at various secondary outcomes. Showed here was the study flow. We just reported these results at the American Heart Association sessions a few weeks ago online. And so you can see that we had about 5,200 patients and over 7,000 patients vaccinations per, over all the 3 years. As we were allowing people to come back each year, they were re-invited to be re-enrolled and assigned the same flu shot strategy that they had been originally assigned to. Baseline characteristics of these 5,200 patients are shown here, pretty standard representative patients in our high-risk cardiac patient population, 2/3 of which had been hospitalized with a prior heart failure in the last 2 years, and 1/3 had a prior MI. You can see here they had many different comorbidities that enriched for the risk of the adverse outcome. They were really well treated on a background of contemporary therapy. So in the MI population, over 90% use of aspirin and statins, as well as almost 85% use of beta blockers. And in those with patients with heart failure, very high rates of ACE, ARB, and ARNI. Of course, not all of them had a reduced ejection fraction, 85% use of beta blockers, very high uses of diuretics, mineralocorticoid receptor antagonists as well. Now, the DSMB stopped the study last year because of the concern of futility after those 5,200 participants were enrolled, and we had 1,700 primary outcome events, which is what we were powered for to detect a difference between the two outcomes. And as you can see in this Kaplan-Meier curve, there was no difference between those who were vaccinated with the high-dose vaccine compared to the standard dose vaccine for all-cause mortality or cardiopulmonary hospitalizations. Both in terms of that primary endpoint, which I might point out again, that the rate of those endpoints are almost 45% per 100 patient years of follow-up, so very high rates of the outcomes, but also for cardiovascular death or hospitalization within each season, or other ways of looking at it, all-cause death as well, and recurrent events, the total amount of burden of disease, there was no significant differences between the two arms of the study. Interestingly, there were very few hospitalizations related to influenza or pneumonia, and there was no statistical difference as well between the two vaccine strategies there as well. In terms of adverse events, it's very well tolerated, each dose of the vaccine, although with the higher dose vaccine, there were more local side effects as in pain, swelling, and myalgias compared to the standard dose vaccine. But in terms of any severe reactions, in terms of any really life-threatening side effects, there were very low rates of any severe reactions. There was no difference between the two. There are 2 ongoing influenza cardiovascular outcome trials still ongoing. One on the left-hand side is studying 5,000 patients with heart failure around the world in developing economies, and they're actually studying a placebo-controlled study against a trivalent influenza vaccine with the primary outcome of CV death, non-fatal MI, non-fatal stroke, or heart failure, and that should be reporting out in the next year. As well, on the right-hand side, those that was studied in Sweden and a few other countries around the world, the AMI study is studying high-risk STEMI or non-STEMI patients and are being, again, randomized to a placebo vaccine or influenza for coronary event reduction or all-cause death. So that'll be a very interesting study to look at as well, whereas we did not have a placebo in our study. So even though there may be no difference between 2 different strategies of vaccine, and so vaccination is very important regardless, and it doesn't really matter according to our new study with the strategy. And so in summary, influenza is a contagious respiratory illness that ranges in terms of the disease severity. Older people with chronic conditions are at the highest risk. The flu vaccine may be effective at reducing pneumonia and cardiac hospitalizations, including heart failure. High-dose vaccines appear to be no more cardioprotective in high-risk patients than standard dose vaccines, but there are still some ongoing large CV outcome trials that further improve our understanding of the cardiovascular benefit in patients with heart failure and MI that we look forward to hearing more about. And with that, I thank you for your attention and look forward to the discussion.